Good afternoon, everyone. Um, I'm not seeing myself. Okay, good afternoon, everyone, and welcome to Health Updates brought to you by TVUP. We are into our 265th episode. My goodness, 265th episode. Thank you for being a part of this credible online community. And to all of you who've just discovered us, welcome po. I'd like to greet all of you who are watching on the webinar and those of you who are watching on the playback. So on this particular episode, we are focused on mycetoma, a disease many people have heard of only when it is already causing serious problems. And maybe many of you have not heard of it. I mean, I heard about it once a long time ago, but I forgot. So today we focus on a simple but important question. What is mycetoma? And why does the foot enlarge? Bakit lumalaki yung paa? Nakatakot yata yun, lumalaki ang paa. Anyway, mycetoma starts quietly. A person may step on a thorn or get a small cut while walking barefoot, and tiny germs from the soil, could be bacteria, could be fungi, enter the skin. At first, there's almost no pain. So people often ignore it, but over time, the germs slowly grow and spread deeper into the tissues of the foot. As the body tries to fight the infection, it creates swelling and thick tissue around the affected area. So we're going to hear about this some more. The swelling gradually builds up month after month until the foot becomes bigger and it doesn't look like a foot anymore. So there are small openings called sinuses that may form on the skin, releasing fluid or tiny grains that are typical of mycetoma. If left untreated, the infection can even reach the bones, making the enlargement worse and causing disability. Maybe you could even lose your foot. Let's hear from our doctor. So today's webinar aims to raise awareness, encourage early treatment, and help communities understand that mycetoma is preventable when caught early and it's treatable, so that we can protect people who have this kind of a problem. So I'm Susie Pineda Mercado. I am your host for today, and it's a pleasure to be with you. See all the familiar names in the chat, and I'm also very happy to be here with my co-host, Dr. Raymond Sarmiento. Raymond, welcome to the webinar.
Hello, Dr. Susie. Thank you so much. Good morning, good afternoon, good evening po sa lahat. Sorry, I have a internet connection problem, but I'm
Oh,
very happy that I'm here and will be our 260th episode po, Health Updates webinar series brought to you by the University of the Philippines. So thank you po for being part of our credible online community. And to all those who just discovered us today, welcome po at sana po marami po kayong matutunan in a very important topic. Hindi po siya masyadong napag-uusapan. And it's about fungal infections po. Ano po? So, mycetoma, ano po ba yung alam po natin sa mycetoma? Narinig na po ba natin yon? Ano po ba yung mga gamot patungkol po sa mycetoma? Alam po ba natin na ito po ay isang chronic granulomatous and progressively destructive na infection of the subcutaneous tissue? And really, meron pong maybe 80% of clinical presentations po, no, it results in debilitating morbidity. Pag-usapan po natin, very, very happy that we have our excellent panel of speakers for today. Ano po ba ibig sabihin ng clinical suspicion po, no, patungkol po when we are trying to diagnose it? What are the distinctive characteristics po niya? Are there any advanced imaging techniques patungkol po rito? And what are the public health strategies and how to mitigate the risk, patient education, and prevention in endemic settings? So this is the Health Updates program, and we are your hosts, Dr. Raymond Sarmiento, and also, as mentioned, Dr. Susie Pineda Mercado also with me.
okay, thanks, Raymond. Let me just quickly inform people that aside from being on the webinar, you can watch this again on the TVUP YouTube channel. And actually, I encourage people to go to the TVUP YouTube channel. You will see so many things you can learn, so many webinars, so many informative sessions that is free. No, so hindi lang itong health updates, but so many different things. So explore that. We're also on the UP System Facebook page, UP Facebook page. And of course, we are on TV, UP Signal TV channel 101. Raymond, do you want to introduce our speakers?
So our speakers po for today, very, very important, Dr. Maria Cristina Filomena Batang. She is faculty with the Department of Dermatology at the Philippine General Hospital. And reacting to her presentation is none other. So we've already had her before, but very happy that we will have her again. This is Dr. Evelyn A. Rojas. So Dr. Eva, as you know, is the professor and chair of the Department of Medical Microbiology at the UP Manila College of Public Health. She's also a renowned infectious diseases specialist, also at the Philippine General Hospital. Okay, maybe we go into the video, Dr.
Here's the video,
Susie.
Raymond. Our TVUP team usually goes out to the field, and as you know, they take a person on the street. And the questions that they asked were, sa tingin ninyo, kung namamaga ang binti, lumalaki ang paa nyo, ano kaya ang sakit na ito? Actually, ako, Raymond, nung nabuntis ako, lumaki yung paa ko eh. Napatanong.
Oh, okay.
Okay, lumalaki ang paa. Pero ito kasi namamaga. So, anong klase kayang doktor ang kailangan tumingin sa inyo kung lumalaki yung paa nyo? Anong klaseng mikrobyo ang nagiging sanhi ng paglaki ng paa? Ano ang mga paniniwala sa pamamaga at paglaki ng paa? At sa palagay nyo ba ang amag or fungus ay nagiging sanhi ng pagpapalaki ng paa? So yung mga may alipunga, ewan ko kung yun. Noon time, ano? Anyway, sige, over to TVUP. Let's listen to our persons on the street.
Personally, I don't have any experiences. Never rin ako naka-witness in person. But based on the medical shows that I've watched before, it can be caused by infection or like exposure to certain substances.
Sa mga virus, ganun. Baka nakuha sa mga baka, ganun. Or may sugat, tas na-infect lang.
Parang hindi ko familiar na lumalaki yung paa.
It's probably like one fungal infection. And I think, I'm not sure, but I've had a relative kasi who had diabetes, and I've noticed that parang one of the symptoms or like side effects of this diabetes was like the enlargement of like their foot or the lower leg area. So,
Parang may narinig na ako tungkol dyan. Ito yung parang kagatang lamok na nagdudulot ng pamamaga ng isang parte ng katawan ng tao.
That's something that I'm not familiar with as well. Pero since it might be infected, I believe the right doctor that should be called is a virologist.
Wala akong ma-recommend pero mas maganda kung magpapacheck up din talaga.
Saan ba siya? Sa family doctor? Ganun? Walang idea ko anong klaseng doktor.
I mean, okay, I know for foot you need a podiatrist, but like for other, like with regards to like the foot itself or whatever disease is entering the foot that is causing it to enlarge, I'm not so sure.
I just think na in general, yung mga maduduming bagay or yung mga stuff na may rust ay nagkakos ng mga ganong conditions.
Siguro sa mga baka, yun, makakuha ko ng mga sakit. Tapos, madaming pwedeng mag-sakit.
Di ba yun yung sa pag lumulusong sa baha? Ano ba yun? Hindi siya ako sa familiar dyan. Sa ganyan. Ito yung pag nakagatang lamok na mamaga yung isang parte ng katawan ng tao na parang lumulobo siya. Una maliit lang hanggang palaki ng palaki. So parang pilin something yung pangalan ng pilingitis. Parang ganun yung pangalan ng sakit na ito.
I don't know actually.
Basing my beliefs sa mga pinagsasabi ng mga nakakatanda, it could be caused by pasma or anything related to that.
Pwede siya maging kusa. Pero mostly kasi nakakuha talaga siya. Sa environment lang din. Kung sa paligid ka pumupunta, yun. Mas maganda mag-ingat ka lang din talaga.
Masakit. Parang yan eh. Ano ba yun? Yung lumalaki. Elephant chassis ba yun? Ay, sa totoo parang apektuhan kasi yung yung paggalaw ng isang tao dahil medyo mabigat yung parte ng katawan. So hindi siya normal na nagiging galaw ng isang tao.
yun nga, like as previously mentioned, maybe you have leptospirosis, you have like an open wound there, and then it can get in, and then it can compromise your immune system and just affect the entire foot already. So, but with the exact fungi or the bacteria that like actually causes it, I'm not entirely sure about that. But to be honest,
Actually, possible. Possible siyang makuha dun. Madaming possible na makuha ng sakit. And isa yun sa mga pwedeng maging reasons para maging mamatay pa.
Parang wala akong idea ko nung ano yung ama fungus. Parang wala akong background ko ano yung meron siya. Hindi ko alam eh. Hindi ako pamilya.
I don't think so. Maybe merong correlation since yung fungus can thrive on dirty environments, but I'm not sure if it directly causes stuff like that.
Okay, thank you very much, TVUP and Raymond. Very interesting person on the street. No, of course, some people talked about very technical na, no, filariasis, elephantiasis na. Kagat ng lamok nga naman yun, no. So I think when we listen to our speaker, we will also think about the differentials because it's not just one thing that can cause swelling in the foot, but there is a particular type of swelling of the foot that is caused by that is mycetoma. So anyway, Raymond, let's go to the certificate of attendance.
Yes, thank you, Dr. Susie. So, just a little bit of housekeeping po, no? So, we give out certificate of attendance to those who have watched at least 50% of the webinar duration. So, I think there is only one person who has emailed us during the week after I checked, no? Asking for just an inquiry on her records. But if you have any questions or concerns, feel free to email us at our up.edu.ph email account. For our webinar today, we'll have our standard panel discussion format. After our two speakers have presented, will be followed by a Q&A session. So we'll get our webinar underway now, Dr. Susie.
Yeah, let's go. So our first speaker, our discussant is, as mentioned by Raymond, a dermatologist, Dr. Christine Batak from the Philippine General Hospital. Dr. Batak, please welcome and please take the floor.
Good afternoon.
Hi, Christine.
Good afternoon po.
Okay. It was very interesting to listen to the points of view of the people in the street. I enjoyed those clips. Okay, good day. I am Dr. Christina Bata. Today, we will take a look at mycetoma, which we may refer to as an impact or implantation infectious dermatosis, since infection is usually associated with traumatic inoculation of causative microorganisms into the skin. Let us know more about this implantation infectious dermatosis as we accompany Kiko, the farmer from Balacangyan, a fictitious rural barangay in the northern island of the Philippines. Invento ko lang po yung Balacangyan. Kiko, a 30-year-old farmer, grew up working in the rice fields. He was once known as the boy from Balacangyan, a very cheerful, outgoing little boy who enjoyed watching the fields transform from flooded fields to paddy fields filled with golden rice stalks. He met the love of his life at a young age. Life seemed a bed of roses until he noticed a nodule on the dorsal surface of his right foot, which gradually enlarged into a firm mass with multiple sinuses emitting dark grains. So from the young man from Balacangyan, Kiko became known as the man with the swollen foot from Balacangyan. This had affected him not only physically but also psychosocially, and in his mind, he is now Kiko, the swollen foot from Balacangyan. He has tried various herbal remedies with some neighbors suggesting na nakulam siya. Baka may nagalit sa kanyang nuno sa punso. His deformed foot had affected his self-esteem and he worried about the future. He was thinking that the mass would further deform his feet and that the occasional pain he was feeling would get worse, preventing him from working and providing for his family. He was almost resigned to his fate when he had the opportunity to consult a dermatologist in a skin mission. He was told that his foot mass of 10-year duration may be due to a microorganism and may be managed with oral medicines and surgery. With the help of the rural health unit, he was brought to the tertiary hospital in another province where he was diagnosed and managed as a case of eumycetoma. This story of Kiko is the same story one would read, case report after case report, stories of young men usually involved in agriculture or manual labor who developed foot masses and waited many years before consulting a dermatologist regarding their condition. These working feet of various persons from different parts of the globe tell the same story. These feet tell the same story of neglect, of poverty, lack of employment, and the social stigma experienced by patients with mycetoma. Mycetoma is a chronic granulomatous infection of the skin and subcutaneous tissue. Although once called Madura foot, it does not only affect the feet, but other parts of the body as well. However, majority of the cases reported in medical literature, around 68.7%, involve the feet. Mycetoma is not a new disease. In fact, the term mycetoma was initially used in 1859. But way before 1859, in 1840, Dr. John Gill, while working in a dispensary in Madurai, South India, had described the disease. In 1846, Colebrook named the disease as Madurai foot, although the term was already being used by the natives. This term, as we now know, can be very misleading because aside from the fact that Madurai foot does not only occur in Madurai, it does not involve only the feet. In 1859, Dr. Henry Van Dyke Carter, a professor of anatomy and physiology at Bombay, presented histological sections from an amputated foot. He demonstrated the fungal etiology of the disease and called it mycetoma. In 1874, he published on mycetoma, the fungal disease of India. Now, from this article on the history of mycetoma, I gather that the disease has been reported even before the 1800s. In 1712, Kempfer, a German naturalist, published the first reports on mycetoma from his travels in India and Persia. And way back in the 1200 to 1000 BC, the disease has already been recognized and was referred to as Padaval mica or foot ant hill, owing to the similarity in the appearance of mycetoma to an anthill. Interestingly, anthill worship actually exists and is very much alive in some areas of India. So again, mycetoma is an old disease, but was declared as one of the neglected tropical diseases by WHO only quite recently, in 2016. What makes mycetoma a neglected tropical disease? Like other neglected tropical diseases, it leads to devastating health, social, and economic consequences. It is prevalent in tropical areas and affects the poor and those living in areas with scarce health resources. It causes deformities, which may limit movement and therefore education and work opportunities. Mycetoma is a disease of poverty. It occurs in all age groups, but is most often seen in the age range of 20 to 40 years. Males are more commonly affected than females, and it commonly occurs in field laborers, cultivators, workers whose work involves direct contact with the soil. Individuals who walk barefoot are at higher risk. The term mycetoma is a misnomer. It came from two Greek words, Greek mycos for fungus and English oma for tumor. Thus, mycetoma means fungal tumor or swelling. However, mycetoma is not solely of fungal origin. There are two kinds of mycetoma, eumycetoma for true mycetoma because they are caused by fungi, and actinomycetoma, which are caused by filamentous bacteria. Eumycetoma is more common in Africa, while actinomycetoma is more common in Central and Southern America. More species have been found to cause eumycetoma compared to actinomycetoma. However, more than 90% of eumycetoma cases are due to a few species. Most are caused by Madurella mycetomatis. The most common agents of actinomycetoma are Actinomadura species, Streptomyces somaliensis, and Nocardia species. What can we say about the prevalence of mycetoma in the Philippines? This is the earliest record of mycetoma in the Philippines, published in the Philippine Journal of Science in 1907. The agent isolated was Streptothrix freeri, a filamentous bacteria. So the first case in the Philippines was actually a case of actinomycetoma. This article by Reyes, published in Acta Medica Filipina in 1963, describes eumycetoma in 3 patients caused by Penicillium funiculosum, Madurella grisea, and Scedosporium apiospermum. Other case reports on eumycetoma was published in 2001, 2009, and a few other case reports followed. This is a case of actinomycetoma published in 1998. In 2017, this review estimated the incidence of mycetoma in the Philippines at 0.1 per 100,000 population per year, based on the number of cases seen in training institutions of the Philippine Dermatological Society in 2015. This is most probably an underestimation of the actual value. How about mycetoma in Asia? According to this article on mycetoma in Asia, published in the Asia Fungal Working Group website, many of the cases in Asia are from India, Iran, and Yemen. In India, where the incidence seems to be highest in Asia, Madurella mycetomatis is the most common agent in both Northwest and South India. In Northwest India, Madurella mycetomatis is followed by Madurella grisea and Aspergillus nidulans, whereas in South India, Neosetelidium dimidiatum and Aspergillus flavus are the next most common. Actinomycetoma makes up majority of mycetoma cases in Iran and Thailand, whereas most cases of mycetoma in Yemen are eumycetoma. How about mycetoma in the world? This figure shows the Mycetoma Belt, the region that extends from 30 degrees north of the equator to 15 degrees south of the equator. In this systematic review published by Emery and Denning in 2020, they included data from 332 papers, which reported 19,494 cases all over the world from 1876 to 2019. In this figure, countries that are shaded purple have at least one published case report of mycetoma. Mycetoma has been reported in 102 countries and from every continent except Antarctica. So notice that the Philippines is also shaded purple. So we do have case reports from our country. This figure shows the number of cases reported from the various countries. The darker the shade of purple, the greater the number of cases. Most of the cases were found in Mexico, Sudan, and India. This shows the ratio of eumycetoma to actinomycetoma in the various countries. The bluer the shade, the more predominant are eumycetoma cases. Looking at the figure, the map seems more pink than blue, consistent with the finding that actinomycetoma accounts for 60% of cases worldwide, while the rest are eumycetoma. How did Kiko's mycetoma get off on the wrong foot? How did Kiko's mycetoma start? The causative agents, both bacteria and fungi, are found in soil and water. Traumatic implantation by thorn pricks, wood splinters, and accidental cuts introduce them to the skin, eliciting local and systemic host inflammatory reactions. As bacteria and fungi proliferate in the subcutaneous tissue, host tissue responds with the accumulation of neutrophils, the release of cytokines and enzymes, leading to the digestion of the subcutaneous tissue, then the breakdown of the skin barrier, forming the draining sinuses and discharging grains with different colors, sizes, and textures. How do we put the foot down on Kiko's mycetoma? How do we diagnose mycetoma? We diagnose mycetoma using a variety of modalities, mainly clinical, assisted by imaging, and other lab procedures. The clinical diagnosis of mycetoma rests in the presence of the clinical triad of painless subcutaneous swelling, sinus tract formation, and discharge that contain grains. So the way I remember this is by using the mnemonic MSG, mass, sinus, and grains. Mycetoma is usually painless, which may be due to the anesthetic effect of substances produced or nerve damage which may be present in the later stages of the disease. Some patients may experience pain, and this may be due to the expansion of the bone by the grains or secondary bacterial infection. We can also differentiate eumycetoma from actinomycetoma clinically. Eumycetoma progresses slowly, whereas the course of actinomycetoma is more rapid and inflammatory. Eumycetoma lesions are usually localized and well encapsulated with well-defined margins. Actinomycetoma lesions are diffuse with ill-defined margins. Sinuses and fistulas in eumycetoma are few, proliferative, and protuberant. Actinomycetoma sinuses are many, depressed, and flat. Bone invasion in eumycetoma is delayed, while actinomycetoma is rapid. Lymphatic spread happens occasionally in eumycetoma and frequently in actinomycetoma. Veins proximal to the lesion in eumycetoma are commonly dilated, while in actinomycetoma, they are seldom dilated. The color, size, and texture of the grains can help us differentiate between eumycetoma and actinomycetoma. Certain microorganisms tend to produce grains of a certain color. Black grain is almost always fungal in origin. As we can see here, the grains produced in actinomycetoma are never black. If we see red grains, then we are almost certain that we are dealing with actinomycetoma. However, if the grains are white or yellow, then it may either be eumycetoma or actinomycetoma. In this case of mycetoma, the grains are white, which means the case may either be eumycetoma or actinomycetoma. Also, eumycetoma produces larger grains compared to actinomycetoma. Let's move to imaging. Imaging is required to determine a mycetoma site, size, extent of bone and tissue involvement. With X-ray, we can detect tissue and bone involvement. Here we see soft tissue granuloma, presence of periosteal reaction as indicated by this sun ray appearance. Presence of bone cavities shown here as punched out areas. X-ray can also help differentiate eumycetoma from actinomycetoma. In general, eumycetoma have fewer but bigger cavities, whereas actinomycetoma have more but smaller cavities. Ultrasound is the first-line imaging technique for the diagnosis of mycetoma. It offers the following advantages. It is available in many centers. It is non-invasive and is relatively cheap. It may be used to guide specimen collection for fine needle aspiration cytology and biopsy. It can differentiate between mycetoma and non-mycetoma. It may be used to determine the extent of the mycetoma to plan surgical incision and procedure. It may also differentiate between eumycetoma and actinomycetoma by looking at the hyperechoic structures, which are the grains. In eumycetoma, grains are large in size, few in number with well-defined margins. Grains of actinomycetoma are small, numerous with ill-defined margins. The dot and circle sign may be seen in ultrasound and MRI. In MRI, it is seen as discrete, small, round, hyper-intense circles with central hypo-intense dots in the hypo-intense matrix of the mass. The central dots are the grains, whereas the hyper-intense ring or circles are granulomas. Let's now move on to microbiology. Among the microbiology lab procedures are direct examination, culture, histopathology with special stains, and molecular studies. KOH smear will reveal fungal spores and hyphae if the patient has eumycetoma. On the other hand, in cases of actinomycetoma, gram stain may reveal gram-positive branching filaments or acid-fast filamentous bacilli. Fungal hyphae may be differentiated from filamentous bacteria based on size. Fungi have bigger diameter at 2 to 6 micrometers, where actinomycetes are thinner at 0.5 to 1 micrometer. Part of the tissue excised for biopsy is sent for culture. Several culture media are used, including sabrodextrose agar with or without antibiotics for fungal culture, and blood, brain-heart infusion, and Lowenstein for the isolation of actinomycetes. Histopathology with special stains is very useful in diagnosing mycetoma. For eumycetoma, periodic acid shift and Gomori methenamine silver stain are used to stain the fungal elements. In this case of eumycetoma, H&E revealed brownish granules composed of spores and hyphae, consistent with the matriaceous fungal agent, surrounded by a eosinophilic amorphous rim. PAS stain highlighted the spores and hyphae. In this case, H&E showed thin filaments characteristic of actinomycetoma. In mycetoma, accurate identification of the pathogen is considered the key to correct diagnosis and therefore therapy. Conventional techniques make use of morphologic and physiological properties of agents to identify them. However, most mycetoma agents, the actinomycetes, may be difficult to culture, and the fungal agents are non-sporulating, making morphological identification tedious, if at all possible. Nowadays, molecular techniques have been used to provide accurate identification of the agents. However, the sad thing is, it is not available in many low-resource settings, which unfortunately is the setting where patients with mycetoma are diagnosed. This is a flowchart which may be used in diagnosing mycetoma using the modalities which we have just mentioned: clinical, imaging, and lab procedures. So foot swelling is not solely caused by mycetoma. Earlier, among the ones interviewed, somebody said lymphatic filariasis. That's a very good differential. Other differentials include, as we can see here in the chart, are yaws, chronic bacterial osteomyelitis, other deep fungal infections such as coccidioidomycosis, pheohyphomycosis, lobomycosis, paracoccidioidomycosis. Another common one is botryomycosis, which is usually caused by other bacterial agents, mostly by Staphylococcus aureus. And then malignancy can also appear the same way. Here are some photos of mycetoma patients we have seen at the PGH Department of Dermatology over the past 2 years. One of these 3 is eumycetoma and 2 are actinomycetoma. Can you tell which is actinomycetoma and which is eumycetoma? Actually, it's not really possible, right? Even I would have a very difficult time just clinically diagnosing which is eumycetoma and which is actinomycetoma. So the first 2 are actinomycetoma cases, and the last one is a eumycetoma case. I'd just like to draw your attention to the fact that most of them were diagnosed after many, many years. They've been keeping the mask there, and they haven't been diagnosed. No. For the first case, it took him 10 years. The second case, 15 years. These 2 cases were both misdiagnosed as extrapulmonary TB, and they were both offered amputation. The third case is that of a 61-year-old male who have had the lesion for 40 years. So going back to Kiko, our fictional patient, how do we help Kiko find his feet again? After going through imaging and lab procedures, Kiko was diagnosed to have eumycetoma. After diagnosing Kiko, how do we manage him? Eumycetoma is usually treated with combination of antifungal and surgical excision. Itraconazole may be given at 400 milligrams once a day or 200 milligrams twice a day. Antifungals are usually given for at least 6 months to many years, with an average of 12 months. Actinomycetoma is treated with antibacterials. First line of treatment is cotrimoxazole. Compared to eumycetoma, actinomycetoma has a much higher rate at 90%. Eumycetoma, even with surgical management, has a cure rate of around 40% and has a recurrence rate of 27.2%. Eumycetoma that are less than 5 centimeters in diameter may be managed with wide local excision, followed by itraconazole for 3 months. If the lesion is 5 to 10 centimeters, wide local excision is followed by itraconazole for 12 months. If the lesion size is greater than 10 centimeters with bone involvement, 6 months of itraconazole is recommended before surgery, and after surgery, itraconazole for 6 to 12 months is advised. Antifungal administration helps in size regression and hardening of the lesion capsule, facilitating excision of the lesion and preventing leakage of the grains. Now, how do we get our feet wet to help people with mycetoma? Here are some suggestions. In the community setting, we can encourage the wearing of protective clothing and footwear to lessen the risk of traumatic implantation. We can promote good nutrition, which would hopefully translate to healthy individuals who are able to mount enough immune response to halt the proliferation of microorganisms even when they get inoculated to the skin through traumatic implantation. We can promote a clean environment. Some studies associate the presence of animal waste where people live and work as a risk factor for the development of mycetoma. This has been hypothesized to be the source of the causative agents in some cases. Let us promote proper health-seeking behavior. That is for patients to consult early and not to let these lesions linger for years. Unfortunately, lesions are painless, which may cause patients to delay consult. However, good health-seeking behavior of patients will only be useful if the health workers they consult are aware of the existence of mycetoma as a disease entity. Therefore, we should promote increased awareness of mycetoma among healthcare workers and encourage referral of these cases to specialty care to prevent complications. For chance favors the prepared mind. WHO has designed this online training on mycetoma, and this is being offered for free. Here's an interesting trivia. Some would assert that mycetoma appeared in literature much earlier than 1846 and that it had found its way in Greek mythology. Some say that the persistent festering wound on the foot of the Greek warrior Philoctetes after he was bitten by a snake on his way to fight against Troy was actually mycetoma. The foot was described as diseased and eaten away with running ulcers in a flow of black blood and matter. Like Philoctetes, our mycetoma patients are warriors and endure much suffering. Hopefully, armed with better knowledge, we health workers will be able to give our mycetoma warriors like Kiko a better tomorrow. Thus, from thinking of himself as the swollen foot from Malacanang, Kiko will again be the farmer from Malacanang. This talk is a product of several lectures I've given in October 2022 and June 2025. Another reference is a lecture given by a friend and colleague from Uganda, Dr. Felix Bongamin. I wish to thank Dr. Criselda Cruz, Dr. Hannah Chito, and Dr. Francis Reyes for sharing their cases with me. These are some of my references. Thank you very much for your attention.
Thank you very much, Tin. Ako, Raymond, what a great and I think, again, it's one of those presentations you want to go back and listen to it, look at it. So maraming salamat din. Very informative and I think something relatively new for our audience with, a lot of insight. I love the way you also presented it. I think your presentation was very interesting. No? Parang color photographs and all of that. Raymond, over to you for our reactor.
Thank you.
Thank you, Dr. Susie. Thank you also to Dr. Batak. So for our reactor today, she is the professor and chair of the Department of Medical Microbiology, also the infectious disease specialist po, no, from the Philippine General Hospital. So please welcome again to your screens, Dr. Evelyn A. Rojas. Dr. Eva.
Thank you, Dr. Raymond, and good afternoon, everyone. So I just want to reiterate the comment of Dr. Susie to Dr. Tin Batak. Thank you very much, Dr. Tin, for that excellent lecture about mycetoma. So again, just a brief reaction. So just reiterating, mycetoma is one of the most striking examples of how a disease can be medically recognized. So unlike maybe other disease manifestations wherein it's really difficult to identify. So mycetoma, as discussed, well discussed by Dr. Tin a while ago, very obvious. No, however, they say it is still socially invisible. No, so the paradox of that. So classified as a neglected tropical disease, mycetoma affects some of the world's poorest and most underserved populations. So most commonly, agricultural workers in rural communities. So learning about this condition evokes a mix of concern, empathy, and reflection on the larger systemic issues that allow such diseases to persist. So mycetoma is not just only a clinical entity, as again in the presentation of Dr. Batak, but also it is actually a disease of social and public health challenge that reveals inequities in healthcare access, poverty, and global attention. So what stands out most about mycetoma is the silent progression of the disease. So it begins with a small, often painless nodule, which many patients may ignore either due to lack of health literacy, so they don't know about it at all, or maybe they are aware but they have financial limitations, hence they cannot go to the nearest health centers or to the hospitals, um, or the distance from the healthcare facilities. So over time, this seemingly minor lesion grows into a chronic infection that destroys the tissue, causes severe deformity, and may eventually lead to disability or even amputation. So for a disease with such devastating consequences, it is troubling that so many patients endures this for years of suffering before receiving proper evaluation and eventually treatment. This really reveals how the burden of the disease is deeply intertwined with the social determinants of health. So we all are aware of that. So it's not just a medical condition, but involves the social determinants of health. So from a health professional's perspective, so mycetoma pushes us to question our assumptions about global health priorities. So why does a disease that causes so much disability remain so overlooked in research, funding, and policy? The answer lies partly in the socioeconomic profile of affected populations. So mycetoma primarily affects individuals who already face layers of disadvantage: poverty, geographic isolation, limited access to healthcare, and lack of representation in national and global health agendas. So as a result, their needs are often overshadowed by more immediate or high-profile health concerns. This neglect reinforces a cycle where disease affecting the poor remain underfunded and under-researched, perpetuating its impact. Learning about mycetoma this afternoon highlights the importance of early detection. So that's well emphasized by Dr. Tin a while ago. Community education and primary care strengthening. A significant part of the harm caused by its disease is actually preventable. So with timely recognition and accessible treatment, progression can be halted before disfigurement occur. So this underscores the critical role of grassroots health professionals in addressing the concerns about mycetoma. So for public health workers, it becomes clear that addressing mycetoma requires not only clinical treatment, but also social mobilization, awareness campaign, and policy advocacy. On a deeper level, mycetoma challenges us to reflect on our responsibilities as healthcare workers. Responding to mycetoma requires more than scientific knowledge, but it demands empathy and commitment to health equity. So in conclusion, mycetoma is more than an infectious disease. It is a lens through which we can examine the intersection of medicine, society, and even inequality. Understanding it broadens our perspective on patient care and public health, reminding us that the true measure of health system is how well it serves its most vulnerable members. So as future healthcare workers or as health professionals, we are challenged not only to treat the disease, but also to confront the injustices that allows the condition like mycetoma and even other neglected tropical diseases to flourish unrecognized. So by doing so, we contribute to more equitable and compassionate health landscape where no disease and eventually no patient is neglected. So thank you. Thank you, Dr. Raymond.
Thank you so much. Thank you so much, Dr. Rojas. Maraming salamat po. Dr. Susie, we will call in Dr. Batak again for a Q&A session po. No?
Yeah, very, very interesting. And also, Evelyn, maganda yung perspective, no? what's the responsibility of society, no? And I think, there are many conditions that are like this, but this one seems to be really terrifying. So I have a question for Tin. Tin, ang galing mo talaga.
Hello.
Tin, itong question ko,
Opo.
bakit sinasabi natin na hindi siya painful sa simula? I mean, something growing like that, no? Tapos may exudate pa. Meron pang mga grains na lumalabas. How can that be painless? What's happening
So
in
what
that
one of the
absence?
hypotheses is the fungus or the bacteria produces some substances that may anesthetize, yung parang nag-numb po,
see.
nawawala yung feeling, or it may also affect the nerves such that the patient doesn't feel any pain.
Parang leprosy, di ba? Yung sa leprosy,
Opo.
ganyan eh.
Pero yeah, hindi naman po siya talagang infection of the nerve, but yeah, parang like maybe it may cause some form of nerve damage such that the patient doesn't feel any pain.
Oo, kasi pain is what should I say? It's a very common reason for why somebody would consult,
That's
no?
correct. Mhm.
But actually, maybe in the city or, in more what should I say, more urban settings, yung umiitim yung paa na namamaga, kinukonsulta yun eh, no? Pero
Oo.
sa palagay ko sa rural area, parang hindi nila
Tinitiis.
pinapansin,
Oo, opo.
not paying attention to it. What is your experience with that?
Actually, like in derm, I would have some patients who consult me just for a very, very small, flaky, scaly lesion in any part of the body. But I can imagine that maybe in the rural areas where healthcare workers are very hard to access,
Yes.
can really delay consult. They may even consult the traditional healers, no, instead of um, healthcare workers.
Oo, and then the other part of it is, baka yung healthcare workers na hindi nila alam.
Yeah, that's right. So yeah, it's possible that we healthcare workers are not aware of the existence of the disease. And here in the Philippines, actually a more common differential or a differential that we usually keep in mind is cutaneous tuberculosis, or yeah. And so some of the patients, they can be managed as cases of cutaneous TB
Right.
instead of mycetoma.
Correct. Okay, Raymond, do we have questions? I think I saw something in the chat, in the Q&A.
Pero
There were some
nakakatuwa po yung
questions. Yeah.
nakakatuwa po yung yung sa interview.
Oo.
Yung isa, ano nga pa pwede? Meron po kasing nagsabi na baka galing po sa fungal infection, no, ng paa, yung parang yung tinatawag nating alipunga or athlete's foot. So yung mga fungus that the fungi that cause mycetoma, they're not dermatophytes. Hindi po sila yung ringworm fungi na tinatawag natin. Ito po yung mga fungi na nandyan lang po sa ating environment, no, nasa soil. Actually, hindi pa rin nila talaga alam kung saan galing. Sabi nga nila, pwedeng galing siya sa animal dung.
Yeah.
Yung doon tapos natatapakan ng tao. So
Correct.
their environment, unlike yung mga dermatophytes po, although medyo meron din po sa environment pala, madalas ay nakukuha natin siya from another person, pwede rin po galing sa animals. Tapos they only affect the superficial epidermis, no? Hindi po siya talaga lumalalim kagaya ng mycetoma.
Oo, so yung mga alipunga, yung mga an-an, di ba yun ang tawag doon? An-an, mga ganun.
Oo. Hindi naman po
Different
sila
kind.
nagiging cause ng
Different
mycetoma.
kind of fungus. Hindi yun ang
Opo.
nagiging
Yes.
mycetoma.
So dapat hindi naman din
Kailangan patingin.
natatakot pag meron tayong
Kailangan
alipunga.
ipatingin.
Pero kailangan
Mga
patingin.
laking ganun, yung mga picture mo na ang laki-laki na nung paa.
Oo.
Oo. Anyway, Raymond, go ahead.
No, the question I think also deserves, this was answered already by Dr. Batak, but I think this deserves a bit more airtime, no? So our health centers daw po, especially in agricultural and rural areas. But yung literature daw po regarding mycetoma, Dr. Bata.
I'm not really aware of the DOH programs as of present, but I know they have a program for neglected tropical diseases. I've sat in one seminar given by DOH, but the emphasis was on leprosy. Alam ko po meron din sila on filariasis. No? So neglected tropical diseases, baka po lang kailangan pa rin ng konting education on mycetoma and other deep mycosis. Dr. Eva Rojas, baka you have more inputs on this?
Yeah po. Thank you, Doc Tin. So I agree with Doc Tin po, no. Under DOH, so we all know there's a separate I think ano ba 'yon, Doc Tin, division in charge of NTDs, neglected tropical diseases. And under this, there are different diseases that they include. But I think mycetoma, Doc Tin, of those NTDs are nasa baba pa sila ng list ng NTDs, ano? Maybe because of its actual incidence, and as you've mentioned a while ago po, maybe diagnostics-wise, the laboratories are not that capable all over the country, and even the healthcare workers. So baka that's the current picture, Doctin, of mycetoma in the country, I can say. So both in government and even in private practice po.
Yeah. Tin, may question ako. What is the cost of treatment? Kasi alam natin mahal yung antifungals, di ba?
Actually, medyo na ano ko na yan na-calculate ko na. Teka lang hanapin ko dito. So, for example, kung fungal infection po, kung fungal infection, binibigyan natin ng itraconazole. Okay? Ang itraconazole is like 114 pesos per capsule.
Okay.
Sa isang araw, 4 capsules yung kailangan nilang inumin.
This is what, 500 pesos.
So, magkano po yan sa isang buwan? Usually, ako po, kung siguro the least amount, yung least duration that I'll put a patient on itraconazole is a year. Kasi nga po, ang taas ng recurrence rate
Okay.
Tapos
So
ang baba rin ng cure rate niya. So,
that's 500 pesos a day.
tapos yung 100 plus na yon, hindi pa po yun yung innovator brand ng itraconazole. Meron pong mga studies na nagsasabi na yung bioavailability ng gamot is also dependent on the brand.
Wow.
Which is, again, another unfortunate thing.
So it's like about, I was just computing it here, it's like something like 200,000 pesos a year.
A year. So, kailangan po talaga ng, importante po din na magkaroon talaga ng advocacy for patients with mycetoma and other neglected tropical diseases. Kasi nga po, unang-una, ang madalas na naapektuhan ay mga mahirap, tapos yung gamot pa mahal.
Evelyn, Dr.
Yeah, opo. If I may add lang po, no, Doctin, no. So this is for the mycetoma per se, no. What if may secondary bacterial infection, Doctin? When it complicates with additional bacterial infection po. So that will be an added antibiotic on the part of the patient. Another medications po. So quite expensive, medyo mabigat ang cost, Doctin, ano. That's why we always emphasize prevention.
Yeah, and obviously it's not covered by PhilHealth, Raimundo.
Yeah.
Baka pag na-admit, Doctin, ano? Maybe if admitted, ma'am, the patient.
But you won't be admitted for 1 year.
Yun nga po.
For the
Pero actually, may ibang regimen na kailangan na amikacin, hindi yung fungal infection na mycetoma, yung actinomycetoma, meron pong binibigay na amikacin. So, usually, kailangan mo ring naka-admit.
Okay, and then so what you're saying 1 year of treatment. No? Ngayon, what happens to the foot? Yun ba, kasi parang mukhang dead na yung tissue na iba, di ba? Parang maitim.
Opo.
Tissue looks dead. Does it peel off? Nagkakaroon ba ng bagong skin?
Okay. I should have shown pala yung some of my, like a patient of ours na gumanda po. Pero yung sakit po kasi niya is actinomycetoma. So makikita nyo po na lumiliit lang din yung mass. And
Saan po siyang lilit lang?
pwede po talagang lumiit. At saka
And then-
nagiging normal na gumagaling po yung mga
Yun.
mga sinuses. So
nagsasara.
eventually, if they respond to treatment, they can have like almost normal feet.
Okay, so bumabalik din sa dati.
Opo. Yun nga lang po, kaya importante po yung umpisa pa lang, yung parang maliit pa lang po yung mass, nagko-consult na sila. Kanina po pinakita ko rin yung mga, 'di ba yung for depending on the size, pwede pa po siyang i-excise eh. Meron pong ganun, pwede pong surgical excision yung gawin. So kung less than 5 centimeters, 5 to 10 centimeters, so mas madali pong i-excise.
Yeah.
Pero syempre kung medyo mas malaki na, aside from excision, kung mas malaki, mahirap ding i-excise, no? Bibigyan nyo pa muna sila ng antifungal para lumiit ng konti yung mass. Tapos, 12 months pa po ng antifungal ulit.
Wow. Okay. Thank you very much. We'd like to continue, but we're running out of time. And so we'd like both of our guests, Dr. Tin Batak and Dr. Evelyn Rojas, for excellent presentations and for sharing your time with the audience. And we hope to invite you again sometime in the future. Raymond, over to you. Thank you so
Thank
much.
you.
Very
Thank you so much. Thank you so much to the Department of
you.
Medical Microbiology, College of Public Health, also to Dr. Bata from the Department of Dermatology. Maraming salamat. So I'll just greet lang po, no? A shout out to those who have joined us from the Camp Navarro General Hospital in Zamboanga City, Zamboanga del Sur, Mariano Marcos Memorial Hospital and Medical Center in Batac, Ilocos Norte, Northern Samar Provincial Hospital, Catarman, Northern Samar, the province of Laguna, Binyan Laguna, City of Antipolo, City Health Office, Davao City, Cebu City, from Bohol, thank you so much. From the province of Bataan, Philippine General Hospital, maraming salamat po. Tony P. Roman Memorial Hospital in Orani, Bataan, maraming salamat po. The province of Ilocos, thank you so much. University of Rizal System Health Services Unit, Olongapo City rin po, maraming salamat. UP, Los Baños, La Consolacion University, Philippines, in Malolo City in Bulacan, thank you so much. Also from the Pasig City Health Department in Pasig, Metro Manila. And then internationally, being viewed by the Lee & Co. Law Firm, maraming salamat po. Juno Sutra in Sarantis, Blida University 1 in Ouled Yaik, Algeria, University of Hail Kingdom of Saudi Arabia, Chonin Hospital in Taipei City, Taiwan, and Island Hospital Penang in Georgetown, Malaysia. So at this point, we'll be flashing on the screen our evaluation poll. It's 5 statements, 4-point Likert scale. So we invite everyone here to answer our Zoom panel discussion poll. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language and technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So, please stay tuned and for next week naman po, another very exciting talk naman po, I think by Dr. Kenneth Hartigan go. Not entirely sure what it will be, but we're hoping it's something that you'll be able to join us po. No? In the meantime, you can still watch us on the Playback TVUP YouTube channel, the TVUP Signal TV channel 101. And before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. You just go to www.youtube.com/TVUPPH. In the live tab, you'll be able to see all 264 webinars. After today, 265 episodes na po yung nakalagay doon. And then if you scoot over, very, very quick trip lang po to the shorts tab naman, we understand everyone very busy naman po. No? So we have some selected presentations that we feature in snippets in the same YouTube channel. Okay, so this formally closes our webinar for the week. Makita-kita po tayo again next Friday from 12 noon to 1 p.m. It's a date.
Together, let's stay updated on health.
Keep safe, keep healthy, and see you online.